Okay. Thank you, Dr. Kavita, for such a kind introduction. And thank you, KREST Imaging Society, for giving me this opportunity to speak. So today I'm going to talk about imaging natural history of multiple endocrine neoplasia syndromes. And I have to tell you something before I start. It's kind of like when I started reviewing all these cases during my routine, like image interpretation, it kind of started like my interest in MEN syndromes grew. And when I started looking at the literature, it's kind of like a Pandora box for me. There's so many things that we don't know, and I discovered while reading this. And I have to admit that not everything that I put in this presentation is something that I remember also. But I'm trying to summarize, like what I'm trying to get here is like a summary, like a big picture of what imaging abnormalities you're going to see in these syndromes, and like a bird's eye view before you go into finer details, because there's so many finer details. And I think we all need to understand the bigger picture before we go into finer details, because just like you see so many findings and we don't know what to do with them. That's where I'm starting. So the first syndrome is the MEN, multiple endocrine neoplasia syndrome type 1. So I'm going to talk about genetic mutations. What are the common and less common tumors associated with MEN type 1, the diagnostic criteria, genetic testing, what are the biochemical and radiological screening tests for these syndromes, and then briefly into epidemiology, imaging findings, what tumors, of all the tumors that these patients have, what are the causes of metastatic disease in MEN1, and then most importantly, like this knowledge of natural history and prognosis of various tumors. That is what I'm going to focus on, and then treatment guidelines and treatment options. So coming to the genetics, it's a very rare syndrome, and the prevalence is like 2 to 3 per 100,000. And it can be due to inherited disease, or it could be due to de novo mutations. So the germline mutations are located in mutations in MEN1 gene are located on the long arm of chromosome 11. It was first identified in 1997. Genetic testing identifies these mutations in about 70 to 90%. And then there are still like patients who present with these findings of MEN1 syndrome in whom no mutations are detected. That could be, it's a phenomenon, there's a name for that, they call it phenocopies, but that could be due to some similar mutations that are not yet identified mutations. And it's a tumor suppressor gene, and tumors develop due to loss of the remaining normal copy of MEN1 gene in the target tissue. These genes encode tumor suppressor gene encodes a nuclear protein menin, which plays an important role in transcription regulation, genomic stability, cell division, and cell cycle control. So I guess genetics apart, the thing that we radiologists need to focus is like penetrance. Like these patients, not everybody with MEN mutation will show tumors, right? But it has very high penetrance. So about 90 to almost everybody, 90 to 100% of the patients, they show primary hyperparathyroidism. About 30 to 70% of the patients show neuroendocrine tumors in the duodenum and pancreas. And then 30 to 40% of the patients show anti-pituitary tumors. This is penetrance by age 50. And then there are several types of mutations. 1,300 mutations are found in MEN gene. And then unlike the other syndrome, which is MEN type 2B, there's no phenotype-genotype correlation, meaning like MEN2B, they have, if MEN, like that mutation, they have mucosal neuromas, or certain kinds of cancers are more prevalent. So that is not seen here yet. I think they're still working on it, and I have to look up the new literature. Maybe there's something changed. But MEN1, 2, and 2B, one of the differences is this phenotype-genotype correlation, which does not exist with MEN1, but it exists with the 2. So coming to tumors, so the characteristic tumor associations are hyperparathyroidism. And you have to note, I'm calling this as hyperparathyroidism, which is caused by hyperplasia. Most of the patients do not have neoplasm as such. They just call it as C-cell hyperplasia. And then the second common characteristic tumor are pituitary tumors. Second one is enteropancreatic neuroendocrine tumors, and the next one is anterior pituitary. So I used to remember in my medical school, and probably all of you, PPP is MEN1, parathyroid, pancreas, pituitary. But these are the common tumors. The less common tumors are thymic, gastric, bronchial, pulmonary, and intestinal carcinoids, adrenal tumors, thyroid adenomas, some of the skin and subcutaneous tumors, CNS tumors, which is meningiomas, ependymomas, and schwannomas, smooth muscle tumors, breast cancer. Those are the other associations. So the diagnostic criteria, obviously, clinical suspicion is very important for diagnosis. And I think that's also where clinical suspicion on the part of radiologists is also important. So the diagnosis of MEN in an individual patient is established by one of the following criteria. So clinically, occurrence of at least 2 out of 3 characteristic tumors. Again, 3 P's, PPP, pituitary, parathyroid, enteropancreatic. And then familial, if the patient has at least one MEN-associated tumor and first-degree relative, we just diagnose it based on only one criteria. And then genetic, it's basically presence of mutation. Regardless of whether the patient has presented clinically or biochemically with the tumor, as long as the mutation is there, they diagnose it as MEN1. And then people are questioning the diagnosis based on clinical context only, because some patients, as I said, like they don't show mutations, and then those patients supposedly show some favorable clinical course. So again, when is genetic testing recommended? In all index case, when there are two or more MEN1 related to tumors, and a first degree relative also. With suspicious findings, like you also, like in an index patient who has suspicious findings, basically multiple parathyroid adenomas before 30 years of age, recurrent hyperparathyroidism at any age, patients with young onset functional pancreatic neuroendocrine tumors, Zollinger-Ellison syndrome at any age, you have to do the genetic testing, multiple pancreatic neuroendocrine tumors at any age, plus a family history of kidney stones, endocrine tumors that are part of the syndrome. And first degree relatives, asymptomatic first degree relatives should also undergo genetic testing. And then symptomatic patients also should undergo, basically every first degree relative, but so before doing genetic testing, I think all these patients deserve counseling so that they know what to expect. And then, so germline mutation analysis is recommended for relatives before we start doing biochemical or radiologic screening, because we want to establish the diagnosis of the genetic mutation before we start doing all these tests. And then biochemical and radiologic screening of individuals at risk of developing. So when do we start screening? So this is still debated, like when do we start screening patients who are positive for MEN gene? So some people recommend at 5, others recommend at age 16 in asymptomatic patients. And then what are the recommendations for screening index? The recommendations for screening in index case and relatives with MEN1 for parathyroid is annual plasma calcium and parathyroid hormone concentrations. For neuroendocrine tumors, there is no consensus. Some people talk about biochemical screening for testing plasma like annual fasting plasma gastrin levels, glucagon, VIP, pancreatic polypeptide. And then imaging is suggested annual imaging studies with either MRI, CT, endoscopic ultrasound. And then for pituitary tumors, it's annual assessment of prolactin and IGF levels, and imaging is every 3 to 5 years. Bronchial, for thymic, bronchopulmonary, and gastric neuroendocrine tumors, CT or MRI of the chest every 1 to 2 years. Adrenal screening is CT or MRI every 3 years. But it's all evolving. I don't know how much of this is practiced also. So these are the guidelines that were recommended. And coming to the common tumors, the most common is the parathyroid. Again, primary hyperparathyroidism is the most common endocrine abnormality. It can be an initial manifestation of MEN1. It can be asymptomatic, or patients may present with nephrolithiasis, peptic ulceration, polyuria, polydipsia, constipation. Typical age of onset is about like 12 to 25 years, and then 100% penetrate, almost 100% penetrance by 50 years. Majority of the patients have due to benign hyperplasia. Malignancy is very rare. It's only 1% of the patients have malignant lesions. It's all like diffuse hyperplasia. And the current initial recommendation, initial treatment recommendation for these patients with parathyroid hyperplasia is they do a subtotal, which is like 3.5 glands are resected, or total parathyroid, or they do total parathyroidectomy. They take out all 4 parathyroid glands and just put one in the forearm, autografting. And at the same time, the recommendation is to do transcervical thymectomy. The reason being thymic-carcinoids it is believed that thymic-carcinoids in general have a very aggressive course. So while the patient undergoes parathyroidectomy, the recommendation is to do thymectomy also. And then imaging studies, all we can see is mostly like multiple enlarged parathyroid glands of varying sizes. So some people do ultrasound neck, technetium 99 MIB. Scintigraphy also is done, particularly in patients. If they're going for surgery, they want to clarify the location, or if it is unilateral glands, or they want to, before exploration, they want to identify where the glands that are causing symptoms are. For initial surgery, it may not be that useful, but if the patient recurs, that is when localizing has higher value. And again, ultrasound, CT, MRI, or technetium 99 system maybe are all the tests. And sometimes, in spite of doing all this, our imaging studies may fail to identify these proliferated glands, also hyperplastic glands. And then these are the newer, increasing newer studies that have been used. And pituitary tumors, coming to the next tumor associated with the MEN1. Initial manifestation, it can be initial manifestation in up to 15 to 25% of the population. Its prevalence is about 15 to 60%. Age at presentation ranges from 5 years to 9th decade. And the mean age at presentation is 38 years. Most common tumor is prolactinoma. About 60% patients present with prolactinoma. And then growth hormone is the next one. Growth hormone secreting tumors are seen in 25% of the patients. 5% secrete ACTH, and the rest are non-functional. Screening tests include mainly prolactin and also pituitary MRI, serum prolactin levels and pituitary MRI. Treatment is similar to sporadic tumors. If it is prolactinoma, they give medical treatment, transperineal surgery, radiation therapy. And then the next tumor is duodenal-pancreatic neuroendocrine tumors. I'm sorry. So this is the second most common manifestation. It is the leading cause of death, even though the other causes are, parathyroidism is more common, but duodenal-pancreatic neuroendocrine tumors are the ones that result in death of the patients. And these can be functioning or non-functioning. So the functioning duodenal-pancreatic neuroendocrine tumors, the most common one is gastrinomas, insulinomas, VIPomas, and then glucagonomas. Non-functioning, we have, the prevalence is around 30 to 70%. That is clinically, either by biochemical tests or imaging or anything. But on postmortem studies, so this is something that I want you to remember, is like nearly everybody has some tumors in the pancreas. So on postmortem study, 80 to 100% of the people have some form of some tumors there. And multiple endocrine tumors are seen throughout the duodenum and pancreas typically, and these are associated with precursor lesions. So the microadenomas, which are precursor lesions, less than 0.5 centimeters without any clinical syndrome, are scattered in the pancreas along with one or more neuroendocrine tumors that are greater than 0.5 centimeters on pathologic examination. And islet cell hyperplasia, enlargement, and atypical or monoclonal clusters are also observed. So this is something, a revelation for me. So we always try to look for small pancreatic tumors in these patients. But the thing is, regardless of whether we see these tiny lesions, there's always this background possibility that the whole gland or anywhere in the gland, there will be small tumors that we may or may not be seen. And if you do pathologic examination, it's very common. So, so that kind of changed my outlook, like in the future, like looking up when I'm looking at looking for small lesions. I try to now focus on bigger picture. So and then there may be synchronous neuroendocrine tumors. So it's not just only symptomatic or asymptomatic, functional or non-functional. Patients may have multiple different types of tumors. And then not only secreting tumors, secreting and non-secreting can be seen also together. And then again, separating them based on just different types of whatever their output is also somewhat artificial, because functional tumors, frequent patients with functional tumors also harbor non-functional tumors. Patients with non-functional can develop hormonally active tumors. And then there can be co-occurrence of different hormonally active tumors. So after that, what is the most common tumor? Gastrinomas is the most common functioning tumor, and they're typically located in duodenal mucosa. And the remaining tumors are predominantly in the pancreatic, predominantly pancreatic. And then malignancy is rare before 30 years of age. However, 50% of middle-aged patients are reported to show malignancy. So in spite of almost universal microadenomatosis in the pancreas, only it is believed that large tumors, that means greater than 2 centimeters, and or symptomatic non-functioning neuroendocrine tumors are only seen in up to 30% of the population. And many patients never develop larger tumors over a long period of time also. So imaging, these patients have like multiple morphologies. Some lesions will be solid, some will be cystic, partly cystic, with enhancing rims. So there are, and they can be seen in the same patient, and maybe an indicator of different types of tumors. And then primary and metastatic tumors and then the other characteristic is like they show very slow growth. And then our typical 2-year stability doesn't apply here. We may have to go back to look at multiple prior studies dating back to like very long time. Endoscopic ultrasound, gallium dotatate PET CT are the most sensitive modalities, but MRI and ultrasound. And then I think this talk is not about like which modality is the best. I think every modality acts as a complementary modality to other modalities. Again, MRI and EUS are reported to be complementary to each other, and each miss lesions greater than 2 centimeters and also 1 centimeter cube volume. EUS is reportedly capable of identifying tumors as small as 0.2 centimeters, but can miss tumors in the pancreatic tail, and is an invasive procedure. Compared to CT, we all know MRI, there's no radiation with MRI. Compared to EUS, cross-sectional imaging with CT, MRI, gallium dotatate provide an overview of the whole abdomen. So US, we are only looking at the pancreas now, and duodenum, and here we get the whole picture of the abdomen. This gallium dotatate is increasingly being used now, mainly, but particularly in the context of surgery. And then it also detects, reportedly detected additional liver and lymph node metastasis, and may provide important information with suspected or non-metastatic disease. Glucagon-like peptide receptor scintigraphy is also emerging as a sensitive and specific modality. And then particularly for insulinoma, this modality, if insulinoma is suspected, then, and you cannot localize it with CT, then glucagon-like peptide receptor, PET-CT is the next imaging modality, and it can help with basically parenchyma sparing enucleations. So PET-CT has been described to detect some tumors, but its still role is like we are still looking at it. Its role is emerging. So metastatin receptor scintigraphy with I-111 has been widely used for the detection of all the tumors except for insulinoma. So coming to the imaging findings, sample patients. So this is like the basic. This is a 36-year-old woman with pituitary parathyroid lesion here, pituitary, and a pancreatic neuroendocrine tumor. So this is one of the, like a classic picture. And then the patient underwent like the treatment that I've described, like subtotal parathyroidectomy for primary hyperparathyroidism, pathology, hyperplasia. There is pituitary adenoma. And here diffusion weighted images sometimes may show better than the regular images on MRI. So this one here is a partly solid, partly cystic lesion. There's a solid lesion here. There are two lesions in the tail. We have to use all the imaging. Whatever we have available, all the tools to diagnose all the lesions. With insulinoma, pancreatic neuroendocrine tumor, which is an insulinoma, and also additional non-functioning tumors. So this is what I was talking about. This patient had MEN1 mutation and hyperinsulinemia clinically. So we did post the abdomen. Some of the adenomas are like this is enhancing portion of the tumor. There's a calcification, and then there is fat around this area. So that is one of the characteristic finding described with insulomas is fat surrounding and enhancing nodular area. And this patient also had additional lesions like tiny nodules here. So they wanted to know which, the patient was not ready for total pancreatectomy just because she had multiple lesions. She wanted to know which one was actually causing insulin production. So this patient, they localized this with hepatic venous sampling after selective injection, and it was coming from the head. So she had selective resection and she's doing fine. So this is another patient, duodenal gastrinomas, and so it's 24-year-old male patient who also had pancreatic neuroendocrine tumors and duodenal gastrinomas. 24-year-old patient, clinically elevated gastrin level. So you see a dominant mass in the tail and then smaller lesions in the remaining pancreas. So at all the studies, there were no duodenal, so since gastrinoma is since patient has elevated gastrin levels, so it's also been worked up for duodenal tumors. And nothing was identified on preoperative imaging. But at surgery, additional like 3 nodules were detected, which were less than 0.5 centimeters in the pancreas, and then 3 nodules in the duodenum, measuring 0.6 centimeters. So the patient underwent distal pancreatectomy, enucleation of the pancreatic neck lesion, duodenectomy with resection of these 3 nodules. And then pathology from the body and tail revealed multiple low to intermediate grade neuroendocrine tumors. Neck nodule showed low grade neuroendocrine tumor. The reason I'm emphasizing is like they may have different grades, different types. Duodenal nodules are low grade. And then even after resecting, the patient's gastrin levels remained elevated. So you have to wonder like what surgery, what the role of conservative management would be also. So moving on to the next one, the gastric, the other less common neuroendocrine tumors, gastric carcinoids. This is predominantly seen in patients with type 2, patients with Jollinger-Ellison syndrome who has hypersecretion of gastrin, which is leading to like precursor lesions. Natural history is unclear, and then, but again, metastases to liver are known to occur. Local tumors are excised endoscopically. Aggressive surgical resection, which is subtotal gastrectomy and D2 lymph node resection, is recommended for more extensive or larger tumors, followed by medical treatment. And then these patients, annual endoscopic ultrasound screening has been recommended for these patients with Jollinger-Ellison syndrome. Thymic gastric carcinoids, as I alluded to before, basically these are rare. These are usually associated with aggressive course, that they're rarely discovered when completely resectable and frequently present with locally advanced disease and distant metastasis. So they are one of the frequent cause of death in these patients, second next to pancreatic neuroendocrine tumors. And that is why this current guideline is we screen them every 1 to 2 years, followed by cervical thymectomy at the time of parathyroidectomy. Once the patient are ready for parathyroidectomy, you also remove these thymus at the same time. Bronchopulmonary carcinoids, the exact incidence, the exact prevalence is unknown. And then their natural history is also very little is known. Usually the patients end up getting curative resection like lobectomy or lymph node dissection. So all these patients have so many lesions and so many tumors. So what are the common causes of metastatic disease? Metastatic disease is mostly common with pancreatic tumors, thymic, and bronchial neuroendocrine tumors, and occasionally with gastric carcinoids. Metastases are typically seen in the liver, lymph nodes, and bones. And it is generally thought that liver metastases in MEN1 are mostly from pancreatic neuroendocrine tumors. And then and I think the statistics, again, like they vary depending on the paper that you cite, but 60% of the patients with duodenopancreatic neuroendocrine tumors have metastatic disease at the time of diagnosis, and this is associated with poor prognosis. The exact primary source of liver metastasis may be unclear. Particularly, this patient may have multiple pancreatic neuroendocrine tumors, and which tumor is basically metastasizing, it may not be unclear. It's a unique challenge in these patients with MEN1. I think we still need future studies to know. Immunohistochemical techniques are playing an important role, but I think we are still a long way there. And then metastatic pancreatic neuroendocrine tumors and GI neuroendocrine tumors are reported to respond differently to different treatments. Cross-sectional imaging plays a role in elucidating which lesions are basically progressing, and also in looking for metastatic disease. Everolimus and sunitinib, and then Y90 radio-labeled somatostatin analogs are the treatment that are emerging. And then atypical thymic carcinoids. I'm trying to remove this box. Okay. Atypical thymic carcinoid with bone metastasis. So this is an example of a patient where I was telling like thymus lesions are very advanced at presentation. So this patient has a mediastinal mass that was diagnosed incidentally while working up for chest pain, no prior suspicion. And then we see lobulated appearance of the thymus, which is the primary tumor. And then the patient also had a large paratracheal lymph node, which is kind of abutting the right heart. You can see that. And by this time, the patient also has bone metastasis. This is a patient who had recurrent thymic carcinoid, and then this patient presented with bone metastasis and retroperitoneal nodal metastasis. So 51-year-old, he had persistent or recurrent hyperparathyroidism after 2 surgeries. And then the patient presented with back pain. So imaging showed a mediastinal nodal disease, which is encasing the arch vessels. And then bone metastasis. This patient also had a nodule here, which is kind of at the superior to the prostate. There was another site of metastasis. And then after few years, after 3 years, this like the pancreas, like how prostate metastasis spread, this spread it to the retroperitoneal nodes. And then the patient has progressive bone metastasis also. So this is a patient with gastrinomas. This patient has multiple duodenal gastrinomas, and then the type 2 gastric carcinoid that I was talking about in patients with elevated gastrin levels, and then pancreatic islet cell neoplasm. So this is a gastric tumor, the duodenal nodule here, and then the patient has nodes, and then pancreas also shows some small new lesions. And again, the same findings here. This is a big, large node. So this patient underwent pancreatic duodenectomy, distal stomach resection, retroperitoneal portal lymphadenectomy. At pathology, multiple neuroendocrine tumors are seen in the duodenal mucosa and submucosa, 2 carcinoids in the resected gastric mucosa, multiple islet cell microadenomas in the pancreatic head, islet cell tumor in the enucleated pancreatic nodule, low-grade carcinomas, and the low-grade neuroendocrine carcinoma in the lymph nodes. And this patient had serum gastrin levels, which became normal after surgery, unlike the other patient. And this is what I still don't know if this is like really, we don't have path proof of it, but the patient at baseline, same patient had a tiny cystic lesion on preoperative imaging, and then it's been growing very slowly, like over a period of 10 years. And here is the size of the lesion. We did a functional imaging study, did not show any uptake. So again, radiologically, like sometimes it has been called as hemangioma, but again, so this slow growth is, to me, is concerning for a metastasis, but again, these patients show slow growth and sometimes may not be able to prove what we are telling also. So we'll keep following on, but at this time, the patient is being observed. So another patient, another non-functioning pancreatic neuroendocrine tumor. This patient has thymic carcinoid and liver metastasis. So he's a 65-year-old male patient. He had nephrolithiasis, symptomatic, and remote history of enucleation of pancreatic neuroendocrine tumors. He has bilateral renal calculi, enhancing lesions in the pancreatic. So you can see all these tail and lesions. And then has very subtle liver lesions. These were all liver metastasis. So he received systemic chemotherapy. And then this is the pancreatic neuroendocrine follow-up MRI of the abdomen. On that localizer images, we found this lesion, anti-mediastinal mass, which is a thymic carcinoid. So we did octreotide study, and then faint uptake in the media. So octreotide did not show any very faint uptake in the mediastinal mass, and marked uptake in the pancreatic neuroendocrine tumor. And liver metastasis did not show any uptake. So again, each imaging modality has its own advantages and disadvantages, and depending on whether they're functional or not, everything. not everything will be picked up on each modality. So this is the thymic carcinoid. This was resected. Non-functioning pancreatic neuroendocrine. So this is another patient where we have used gallium dotatate PET CT. There were only 2 lesions identified on the MRI, but there's another smaller lesion that was identified on the gallium dotatate PET CT. So these 3 lesions were enucleated in this young patient, 16-year-old. Again, the trend is towards doing pancreatic sparing surgeries because these patients will have like long history of multiple recurrences also. So coming to challenges in the treatment of duodenal pancreatic neuroendocrine tumors. So it's still the timing and extent of surgery for patients with this tumor is still controversial. There's not much controversy when it comes to resection of insulinomas. And but when it comes to tumors and glucogomonas, but sometimes most common functioning tumor, when it comes to Zollinger-Ellison syndrome with gastrinoma or non-functioning tumors, then the surgery, there's no consensus on surgical management because the history is unknown, long natural history, low cure rate without aggressive surgery, which is like pancreatic. So these patients must undergo pancreatic duodenectomy, which is like a very aggressive treatment for like relatively young patients. And then these patients also have it's not that these tumors are killing them. They have excellent prognosis for when they are smaller lesions. And also for Zollinger-Ellison syndrome, also it's very well controlled medically, and they have usually a good prognosis. And then again, this is the main reason why surgery is like they have long-term side effects and short-term, like very aggressive surgeries, and they have their own side effects. So the main important thing is like the duodenal pancreatic neuroendocrine tumors are the most important determinant of MEN1 related survival. Recent studies have established low risk of disease-specific mortality with conservative management of MEN1 syndrome that are 2 centimeters or smaller. Liver metastasis from the pancreatic neuroendocrine tumor, which is the most common cause of death in these patients, is uncommon when the tumors are less than 3 centimeters. So at our institution, I think the surgeons usually follow like resection of tumor when it reaches 2 centimeter size. And then historically, peptic ulcer disease due to elevated gastrinoma was the most common cause of death in MEN1 syndrome with Zollinger-Ellison syndrome. But with the effective control of Zollinger-Ellison syndrome with medical therapies, the death rate from this is decreasing and other tumors is increasing. Due to multiplicity of tumor, the exact cause of metastatic disease may not be clear. And then there are no clear markers to identify cases that are risk for progression or death. So in summary, MEN1 is caused by germline inactivating mutations of MEN1's tumor suppressor gene encoding a nuclear protein menin. Hyperparathyroidism is the most common and most common initial presentation and often initial presentation. Functional and non-functional tumors, functional and non-functional duodenal pancreatic and pituitary tumors are next common associations. Our understanding is still evolving of the natural history, and particularly in different locations also is evolving. And imaging plays a key role in diagnosis and treatment of neuroendocrine tumors of the duodenum, pancreas, thymus, and bronchus that show varied biological behavior and aggressiveness. And I think our role is also in showing the aggressiveness of the tumor, how they are progressing. That may be one area where I think our role will evolve. So metastatic disease in MEN1 to the liver, bones, and lungs is commonly seen with pancreatic, thymic, and bronchial neuroendocrine tumors. And the role, timing, and extent of surgery for non-functioning pancreatic neuroendocrine tumors and gastrinomas in MEN1 remains controversial, as they're frequently multifocal, cure rates are low, and balancing goal of tumor resection with preservation of pancreatic endocrine function remains a priority. Often the primary tumor and metastatic tumors show very slow growth, and then we have to compare with multiple prior studies. Coming to the next tumor, which after looking at the MEN1, I think this is much simpler. And you will see that here. So I'm going to follow similar outlines, genetics, subtypes, common endocrine tumors associated with MEN2, screening recommendations, imaging, again, findings and role and limitations of imaging, metastatic disease in MEN2, emerging knowledge and natural history, and emerging treatment guidelines. So MEN2 genetics, it is caused by autosomal dominant. It's an autosomal dominant familial cancer syndrome with germline activating. This is an activating mutation with variable penetration of the RET proto-oncogene. So various types of RET mutations are identified. And unlike MEN1, there are clear associations between genotype and the phenotype. Basically, the age of onset, aggressiveness, as well as other endocrine neoplasms is known. So C634 RET mutation is associated with MEN2A. This is a common one, and M918T RET mutation is associated with, most common associated with MEN2B. So this one, MEN2B, is associated with early aggressive behavior. Incidence is about 1 in 200,000 live births. There are 3 variants that have been described. MEN2A is most common, which is 55. 2B is 10%. Familial medullary thyroid carcinoma is seen in 35%. So what are the common endocrine tumors? So the characteristic tumor in this is medullary thyroid carcinoma. And it is multicentric. Bilateral medullary thyroid carcinomas are seen in 100%. And bilateral pheochromocytomas in 50% of the patients in both 2A and 2B. So in 2A, I think for most of them, it's medullary thyroid carcinoma is often the initial presentation. Usually occurs between 20 to 30 years of age. These patients also show some primary hyperparathyroidism in 20 to 30% of the patients. 2B, the MEN2B manifests in this group, the medullary thyroid carcinoma manifests very early and shows very aggressive course. Medullary thyroid carcinoma develops within the first year of life. Most patients die within 30 years if they're not treated. And they're also associated, this is also associated with characteristic physical appearances, including morphonoid habitus with musculoskeletal abnormalities, weak musculature, hip epiphysiolysis, scoliosis, feet abnormalities, hypermobile joints, ocular abnormalities. They may have corneal thickening, corneal fibers, conjunctival neuromas, mucosal neuromas. They may also have intestinal ganglion neurometastasis and megacolon. Familial medullary thyroid carcinoma is the mildest variant, usually occurs in the 5th to 6th decade, and considered when at least 4 family members develop MTC without other endocrine findings. So again, I wanted to emphasize this medullary thyroid carcinoma, which is a tumor of the parafollicular calcitonin secreting C cells, and it is the principal feature of all subtypes. And this tumor has a very sensitive markers. So calcitonin and CEA are very sensitive markers. It's also calcitonin is also it's specific for MTC. CEA can be seen with GI tumors, but calcitonin is again very specific marker for medullary thyroid carcinoma. And this is the most important determinant of mortality. Prognosis is poor, particularly when there is extrathyroid disease, and survival is improved by early surgical resection. So screening recommendations, genetic testing is recommended for all first-degree relatives of patients with newly diagnosed medullary thyroid carcinoma. So obviously all patients also will get genetic testing. And then Once the genetic testing mutation is positive, then you have to screen calcitonin. Early detection by calcitonin screening and mutational analysis of family members, followed by prophylactic surgery, can be curative. And then the other important thing is pheochromocytomas. These patients can develop pheochromocytomas, and every time you diagnose a medullary thyroid carcinoma, and if the patients are undergoing surgery, we have to evaluate for pheochromocytomas, because undiagnosed pheochromocytomas can lead to adrenergic crisis. So this is a patient with multifocal medullary thyroid carcinoma and left adrenal pheochromocytoma. She's a patient with MEN type 2A, 19-year-old patient with 2A. Here you see one large mass, which is partially calcified. And then calcifications are a feature of MTC. And then a smaller lesion in the left thyroid gland. And the clinicians know to order a study for to rule out basically adrenal pheochromocytoma. So this patient had a screening test at the same time of diagnosis of medullary thyroid carcinoma before surgical resection, and then we diagnosed adrenal pheochromocytoma. So again, if there's one thing that I want to learn from this whole lecture is this thing. So it's important to evaluate for adrenal mass prior to any surgery or invasive procedure secondary to the possibility of sudden death from undiagnosed pheochromocytomas. Every patient with medullary thyroid carcinoma should be presumed to be MEN2A or 2B, and then we have to rule out this pheochromocytoma before taking them for surgery. Again, so these patients, liver metastases are very common, and they can also calcify. So this is a CT about 6 years later, because this patient is showing slow rise in serum calcitonin levels and CEA levels. So there are liver lesions here. You can see faintly enhancing lesions. And I've seen several times these faintly enhancing lesions to be mistaken for hemangiomas, because they just do show arterial enhancement. They may or may not be seen early on the other phases. So they were called as hemangiomas in several patients also. So another patient, 12-year-old female with recent diagnosis of MEN2B, and then she has thyroid nodules, multiple lesions here. She has she underwent thyroidectomy and nodal dissection. So follow-up CT neck showed left paratracheal lymphadenopathy, and then CT chest showed lung nodules. So these are tiny, but you have to, when the serum calcitonin is elevated, you have to look at all of them critically. The MRI showed tiny enhancing liver lesions. I think I was the one which initially I called it as hemangiomas. I didn't know at that time, but then they grew on follow-up imaging. So this hemangioma serum calcitonins kept on increasing, and then the patient showed a progression of the liver lesion. The patient also had an enhancing lesion in the spine here. Even the bone lesions, usually they're mistaken for benign lesions. They may be either called as bone islands. But once you have patient with medullary thyroid carcinoma and have enhancing lesions in the liver or sclerotic lesions in the bones, you have to call them with higher suspicion. So this is a metastasis here. And the patient also has prolonged history of constipation. Their colon is usually dilated, and this dilatation persists on multiple studies. So this is just one example to show you how dilated the colon is. This is due to intestinal ganglioneuromatosis. And these patients may also have, some of them have pectus deformity. So coming to metastatic disease and MEN2, it's commonly seen in patients who are not diagnosed early by screening. Distant metastases with medullary thyroid carcinoma are associated with increased tumor markers. So most of them are followed with clinically also, like they also get calcium, troponin, and CEA. It is important for us to look at the trend of these tumor markers. Common sites of metastasis are lung, liver, and bone. Patients may also develop rather difficult to control secretory diarrhea. Early liver and bone metastatic disease can mimic hemangiomas or other benign lesions. Again, correlation with serum markers and comparison studies will be helpful. So vandatinib, cabazitatinib have been approved, and I think more recently other drugs are also approved. Due to toxicity and non-curative nature of the therapies, as well as variable and often indolent course of nature of MEN, metastatic disease, targeted systemic therapy for patients is generally reserved for those with progressive, advanced, and or symptomatic disease. Recommendations for treatment of medullary thyroid carcinoma. So this is another thing I just want you to remember. So prophylactic thyroidectomy is recommended in the first month of life for MEN2, first 6 months of life for patients with MEN2B. This is associated with highest aggressive mutations, which are usually most commonly codon 918 and very rarely 883. These are the two mutations associated with MEN2B. Before 5 years of age in patients with MEN2A with this aggressive mutation. And then after that, 5 years of age with like next level of aggressiveness, which is all these mutations. And then when serum calcitonin rises or 5 to 10 years of age for mutations with next level of aggressiveness is when prophylactic thyroidectomy is recommended. So, and then approximately 50% of the patients with these two highest levels of aggressiveness, they develop pheochromocytoma. So annual screening for pheochromocytoma should be started at around age 8 years. And for the pheochromocytomas, the trend is towards minimally invasive and cortical sparing approaches to minimize permanent Addisonian trait. And again, as I said earlier, pheochromocytomas should be resected before thyroid surgery to prevent adrenergic crisis. I'm going to say again, the same conclusion is early prophylactic total thyroidectomy is recommended for patients with MEN2, and pheochromocytomas must be excluded prior to thyroid surgery. MEN medullary thyroid carcinoma in type 2B is very aggressive and prophylactic. This occurs at 6 months of age. So I want to end with 3 patients, like since I said imaging natural history, like over a period of time, how each one evolves, with 3 examples of with examples of natural history and few patients. So patient 1, here this patient is diagnosed with hyperparathyroidism at age 25 and underwent resection of 3 parathyroid glands. He's diagnosed with left upper lobe carcinoid at age 30. He developed kidney stones at age 34. And at this point, it led to the diagnosis of, at age 34, he was diagnosed. It led to the diagnosis of MEN1. He got genetic testing. Baseline octreotide scan at age 37 showed a pancreatic mass that was monitored until age 39 when he underwent distal pancreatectomy and splenectomy. So at pathology, there were multiple tumors at surgical pathology. The patient developed hyperprolactinemia at age 46 and is diagnosed with pituitary adenoma. And all this happened before the patient presented to our hospital. So the first follow-up study I have on our PACS is at age 49, and the patient showed residual multiple pancreatic neuroendocrine tumors. I'm just showing a few here. This one is cystic. This one appears solid, enhancing. There's one in the head. Also note that the patient have benign adrenal lesions, adenomas in this. And then we got a follow-up MRI at age 50. The patient has a schwannoma, which was resected. And this is brain MRI at age 52. He had pituitary adenoma diagnosed even before, but this is what I have, the first available study. This is the pituitary adenoma. And then at age 54, we started seeing this tiny subtle liver lesion. It's probably missed here. It was missed here, and then it started slowly growing. At age 58, this one lesion, which has grown. And then things started treatment here. That's why it's started slightly smaller. The liver metastasis is smaller, but again, these pancreatic neuroendocrine tumors, I think they're like more obvious and slightly bigger. At least this head tumor is slightly bigger. So this is age 60. And this is what I was talking about at age 49, 11 years. The growth of this lesion in 11 years, you can compare. It's, I mean, you can see the growth in 11 years, but maybe we won't be able to see for looking at 1 or 2 years. And another patient with MEN2A. So this patient is diagnosed with localized medullary thyroid carcinoma and MEN2A around 64 years of age. Baseline studies, I don't have them. Follow-up after 1 year showed this mediastinal lymphadenopathy and bone metastasis here in the sacrum and thoracic spine. And then follow-up brain MRI 3 years later showed calvarial metastasis. So one of the pathways of spread for this thyroid cancer is through the paravertebral venous plexus, and bone metastasis can be seen without lung metastasis. That's one thing that I've been seeing in these patients. And then the same patient, 8 years after initial diagnosis, showed this faint arterially enhancing lesion, which is arterial and portal. This arterial enhancement, depending on the size, may persist into portal venous phase, and it doesn't wash out typically. This just becomes homogeneous to the rest of the parenchyma in most cases. So this is one of the earliest manifestation of the liver metastatic disease, and then I think that was missed initially, and then after around 12 years, we have multiple liver lesions which have progressed, and then the bone metastasis also is progressed. So 12-year follow-up, like you can see how slowly things spread. And then at 16 years, this liver metastasis has become further larger, and now the patient started developing nodes, retroperitoneal nodes. So now moving on to MEN2B natural history, as I'm depicting. So this is a patient who was diagnosed with localized medullary thyroid carcinoma and MEN2B around age 13. I don't have baseline studies, but the patient developed metachronous bilateral pheochromocytomas. So this is at 6 years from initial diagnosis. You see one lesion, and then at 9 years, you see the second lesion. The patient also recurred at 9 years. This was resected, recurred in the on the left side, and then you see one more lesion on the right side. So he underwent cortical sparing. This was resected on the left side. On the right side, there was cortical sparing surgery. So the same patient, 16 years after initial diagnosis, we see some hilar nodes, lung nodules, and then subtle bone lesions. I think this should, oh, sorry. So this bone lesion is here. My arrow is going somewhere. So this was a sclerotic area. And then 17 years later, like he developed liver metastasis, and then he developed recurrence here in the right adrenal, or right adrenal at this point, because he has lung metastasis, everything. So this right adrenal lesion could also be a metastasis also, because he developed around the same time brain metastasis, extensive bone metastasis, liver, and right adrenal. So once you develop, I think as I've like lectured in my talked about in my previous lecture also. So once the lung metastasis starts spreading everywhere, that is usually kind of a subterminal event. So this patient has a widespread dissemination to every other part, that around 17 years after diagnosis, he died. So another thing that this is the second example and the last case, last example. Another patient with MEN type 2B, this patient was diagnosed at age 12. You can see 2 tiny calcific foci within the thyroid gland. He had history of prolonged submucosal neuromas, constipation, pes cavus since birth. So here you see these calcified nodules. Patient associated with elevated serum calcitonin. He underwent thyroidectomy and selective neck dissection with pathology confirming medullary thyroid carcinoma. He didn't have any bone, lung, bone, or liver metastatic disease, but there were small volume mediastinal nodes, which remained stable over a period of time. So that's why I didn't show. The other feature that I'm finding here is all these patients with have mucosal neuromas, right? And then we see thickening along the nerve roots, like all this. We are seeing like hyper thickened and non-enhancing nerve roots, nerves. So basically, this is cervical region. You see in thoracic region. We see along the cervical nerves, and this is something new also. Like I have also noticed in the trigeminal ganglion region, this is thickened. This is T2, and here is T1 weighted images. They don't show any enhancement. Thickened nerves along the fifth nerve, cranial nerve 5, and also seen along the hypoglossal canal, which I haven't shown here. So this patient, 9 years later, showed findings in the concerning for recurrence in the tracheoesophageal groove that I didn't show, and then a prostate lesion. And we did a dedicated prostate MRI. And you can see like there are multiple T2 hypointense lesions. This is the largest lesion. He got it biopsied. This was biopsied and proven to be medullary thyroid carcinoma. And then he remained stable over a period of 6 years. So this is where we are entering the uncharted territory. So we know that medullary thyroid carcinoma causes mucosal neuromas. We know they can cause pheochromocytomas, but this patient, 16 years after the diagnosis, he developed pituitary-dependent Cushing's disease, and you see a pituitary lesion. These patients are surviving longer, and we're seeing new kind of tumors. So this patient underwent transsphenoidal resection, and it confirmed corticotrophin secreting adenoma. But the brain MRI also showed some enhancing, like you can see the enhancing nodule here along the jugular foramen. So this is a new lesion and has a metastasis along the right C1 arch. And at this point, we don't know. This is very recent. We don't know if these are prime separate tumors, if these are metastases, if we are extending the spectrum of MEN2B now that patients are living longer. And that's it. Thank you.
Thank you very much, Sireesha.
Sorry,
as usual, it's a world-class presentation, and the way you have documented all the natural history of these MENs and then showed the cases, it's really excellent. So I open the lecture for any questions from the floor. I don't see any questions in the chat box either. And
Dr. Jayalalitha is there, her experience in MNJ, how frequently do they see? Sireesha, one question.
Yes, Isha.
Yeah, Dr. Jayalalitha, please go ahead.
I just wanted to tell that it's very good presentation, and she documented, as ma'am said, very well all the lesions. We do come across many of these thyroid and, as she said, the pancreatic tumors, but very few, the very large lesions are identified. The small lesions, as she said, multiple may be there, but which we are, even after resection, they're recurring and all. And so this could be the cause where multiple entities may be present, which are unnoticed with the diagnosis. Recently, I just wanted to tell, one doctor was diagnosed with a carcinoid of the gastric carcinoid. But when we did PET after that for her staging, because she was our own faculty, and then we noticed a lesion in the thyroid. and which literature said there's an association, and she underwent. And there was a nodule, unnoticed, non-functional nodule, even in pancreas. So all three were resected, and she's doing fine, thankfully. But as she showed, there are multiple lesions, and we most of the times in the view of diagnosing only one lesion, and we are very satisfied that that lesion could be the one. And as she said, multiple entities could be there, and which has to be further worked up and properly done, I think. Thank you so much for giving us a broad spectrum of so many lesions. Yes, thank you.
Thank you, Dr. Jailata. Yes, I think in your hospital must be seeing lots. And yes, definitely PET-CT plays an important role. The F18 FDG, but it's limited sensitivity in picking up neuroendocrine tumors. Gallium-68 DOTA scan definitely plays an important role. And of late, we have other tracers tagged with gallium-68, like Exendin, which is very sensitive in picking up insulinomas and gastrinomas. And it's a one-stop shop, like it's a whole body. So right from thyroid, parathyroid, bronchial, GIT, everything you have a broad of visualization of all and it's a molecular imaging, right? We can pick up the lesions very early.
The gallium dotatate show non-functional tumors. How sensitive is that with?
Non-functional, yeah, it's the reported sensitivity is
much less, ma'am. Even we noticed.
But definitely, it is better than FDG and conventional imaging.
So yeah,
for the pancreatic tumors, yes, the 68 is very good. And parathyroid, we have they have tried fluorine F18 labeled choline PET-CTs, which is supposed to be higher sensitivity than these regular other imaging modalities, like other regular technetium system AB scans. And another interesting thing which you told is the screening and the prophylactic thyroidectomy. I think that's very important. With our experience, we have seen some patients with medullary CA thyroid and familial. It's been subsequently, after a few years, I have a family where mother, son, and the daughter, all three were diagnosed to have MTC, and which in the span of 2 years, 3 years, and 4 years, over past 12 years, we have seen all three of them having MTC. And finally, it prompted us to, of late, the recent past, to do the genetic studies. We sent them to All India Institute, and then they have been under follow-up. And the mother is not doing well. Not doing well means she has lung metastasis, and we did FAPI imaging. There's another compound FAPI, that fibrosin activated protein inhibitor imaging, which targets a tumor microenvironment rather than the tumor. So the malignancy of that lady was positive with FAPI. So we tagged FAPI with lutetium. Lutetium FAPI therapy is being given to her. So 2-3 cycles, and then she's doing well for past 18 months. And her daughter also got married, and she's fine. So that's one family we have in follow. And as you said, if we could have done these genetic studies earlier and did prophylactic thyroidectomy there, so that would have helped.
Still knowing the disease, right? We are just like, we are still learning a lot, knowing, and it's just like evolving as we.
So that's the point.
Yeah, I have Kavita, I have Dr. Murli there trying to say something. Dr. Murli, please identify yourself and you could post your question.
Murli, Ishwar.
Yeah.
Thanks. Excellent presentation, Sireesha, and thanks for your inputs, Kavita Garu, doctor. Yeah, I'm an ENT surgeon from UK, so I come across a lot of MENs. Yeah, well done. Just probably, I'll request a personal favor from Kavita Garu and Sireesha. One of my friend's wife, she had hypercalcemia for a long time, and they have done parathyroid surgery, and it's not helping. Still the calcium is high. So probably she might need your input. My friend is, he does a lot of things for Hindu community here. So in the UK, so I might message you personally. Is that okay?
Yeah, I think the next step would be localizing studies, some kind of nuclear medicine localizing studies to see if there is some residual parathyroids, because they can be everywhere.
Ectopic parathyroids too.
Yeah. They can be in the lungs, in the mediastinum as well, isn't it?
Yes.
Residual parathyroids or ectopic parathyroid adenomas. So definitely there is an indication for imaging there for parathyroid. Especially,
so PET scan, you mean?
Need not have to be PET scan. If it is parathyroid, we can do sister baby parathyroid scintigraphy.
Yeah, I'll get back to you. Yeah. I'll take your contact number from Ishwar. Ishwar is my childhood friend. Yeah. Thank you very much.
Yeah, sure. Sireesha, there's one question in the chat box from Krishna Mohan.
Yes, I'm saying I don't have any experience with ultrasound guided ablation, so I haven't come across any cases. I guess if that is high, so 4 parathyroid glands, can you remove them? And then for thyroid tumors, I think we have to, and it's whole thyroid gland. It's not, we are not just treating tumor, right? We're just
total thyroid.
The thyroid gland can be infected or can be affected by the tumor. It's the neoplasm. It's a precursor to precursor condition, right? So whole thyroid gland needs to be removed. So you don't want any remnant there. So I don't know. That's not something that can be advocated, because you need to remove the whole tissue, lymph nodes, and
maybe in inoperable patients or who are not a good candidate for surgical surgery, then maybe it might be tried. I don't know, but it has been tried in certain situations, especially secondary hyperparathyroidism. So I've been treated with alcohol or RF ablations. And even thyroid nodules are increasingly being treated, benign nodules, of course, with minimally invasive therapies apart from surgery.
Yes, because benign nodules, yes, but here I think
malignancies, minimally invasive surgeries, they have been done with the patients, not tolerating well.
As a palliative intent.
maybe symptomatic if they're pressing on the thyroid, on the airway.
But for malignant thyroid tumors, I don't think sound guide microwave ablation.
Yes.
Why do you have to treat benign thyroid nodules?
Cosmetic purposes, mostly for cosmetic.
Oh, you mean the
swelling of the
goiter, huge goiter.
Yes.
Tumors, microwave ablation, is it effective for the size more than 3 centimeters? There must be some size limitation, right?
Maybe,
Yeah, we do that only for compression symptoms. We leave even retrosternal goiters. We leave, big retrosternal goiters. If they're benign, we don't treat at all.
Isha, I just want to tell that you said about secretory and non-secretory. here, this especially gallium-68, it's not secretory or non-secretory. It's the receptor expression on the tumor, which is important here. So if they are expressing somatostatin receptors, then definitely the gallium-68 DOTA, that is the receptor agents, definitely they'll pick up. So rather than secretory and non-secretory, it's the receptor expression which is important here. We are targeting the receptors. Even with the extending, it's the GLP which we are targeting. Glucagon-like peptide receptors, which are expressed on these insulinomas. So it's very small tumors, as small as around 5 millimeters, also can be picked up.
GLP.
Yeah.
So insulinomas are symptomatic and they need to be resected. We need to know where they are and they have to be taken out. I guess the remaining tumors. I mean, insulinomas have a special place in this whole spectrum of diseases. They tend to be symptomatic very early on. I guess once they're symptomatic, they can be resected early on also.
Localization is very important at that time, right?
Localization is important. And here we play a key role. For insulinomas, I think the radiologists are like, play a key role in localization. But for the other like things, it's a bigger picture kind of like, I mean, I stopped like worrying about small lesions. Like, am I seeing this? Am I seeing on the follow-up? So it's like small pancreatic neuroendocrine tumors, like every few years, even every few years, if we follow up, now you can focus on larger lesions. What is reaching 2 centimeters? And how many are progressing or what are progressing? I think our role will evolve there rather than just like what I call like detection, like just detection.
But yeah, Dr. Mahesh is here. DOTA avidity same as lutetium to plan. Yes, no, that time we should not use DOTA. It should be gallium labeled FAPI to plan lutetium FAPI therapy. So FAPI or DOTA, they are the tracers which are tagged to the isotope, that is gallium-68. So DOTA is receptor imaging, FAPI is tumor microimaging. So depending upon the positivity, whether the tumor is positive with DOTA or FAPI, then we label lutetium with either DOTA or FAPI and then treat the patient. So DOTA avidity and FAPI treatment will be a mismatch. So it should be same. The diagnosis and the therapy should be same with the same agent. Isotope is different, but the tracer, yeah, same. And as the small, we have a couple of cases of those smaller liver lesions which are reported as hemangiomas and then subsequently DOTA positive. So there, this PET imaging plays an important role.
Yeah, I think that's you're saying.
They have doubt whether they have metastasis.
I'm sorry. The traditional teaching is like these are hypervascular tumors, so you see arterial enhancement and washout. But they're like a very heterogeneous group of tumors. So they don't follow the textbook rules of hypervascular tumors with washout.
Yes, the tumors which you showed also not very hypervascular. That's what I was noticing, even the mediastinal and the other ones, they're not very hypervascular, which the textbook description, I was just thinking of that.
Well, they say diseases don't read books.
Yes.
We see any like that.
These days with PET, ma'am, there are multiple lesions. We don't know. Every case has multiple lesions, and most of them show hypermetabolism. Some of them doesn't show, and it's becoming very confusing. And the report says so many lesions, and I don't know which are to be given important and not.
there will be a flip-flop. Some will be well differentiated and some will be poorly differentiated. FDG will pick up poorly differentiated tumors, and if they are well differentiated neuroendocrine, they'll be hold on PET, FDG PET. If we do gallium, these well
Maybe more specific.
positive, and then
Yes.
poorly differentiated will be negative. So before going ahead with the treatment with lutetium DOTA, we do both to delineate both, like both well differentiated and poorly differentiated.
Mhm.
Okay, thank you, Dr. Sireesha. Thank you for giving us time again, and with your really excellent topic. And then really we learned a lot with your lecture. And that's the reason for these international webinars. So to exchange your expertise then with us. So thank you very much. Thank you very much for your acceptance and then enlightening all of us. And thank you, Dr. Jayalata, for your.
Thank you, ma'am. Thank you.
It's nice to see you on board.
Thank you, ma'am.
Jagan.
Thank you,
Thank you.
Sireesha. It was very nice having you.
Thank you. Thanks for giving me this opportunity. I know it's kind of complicated and there's some things which hard to remember also for me also, like I'm like reading over the text there.